So, welcome. This is NUR203 Pediatric Nursing. My name is Professor Bogart. I am the lead pediatric professor. I have been at Fortis since 2017. I've taught online and on ground. In fact, I built this pediatric program when they went off of campus and went to online program. So I've been here for the whole duration of it. I know what campus is. I know what you have going on right now. I worked several years understanding pediatrics community and also med surg too. It's a very rough trio. And I know this term's going to get rough for many of you. Where do I focus my attention? What do I study? What's important? So I'm going to try to help you with Professor Harbor to try to get you what you need and to have you understanding, okay, this maybe you should start your project now. And as I keep going, you'll understand what I'm saying. We're going to try to help and guide you through this so that you can succeed here. Darren, please come on camera, please.
Please.
Thank you so much. So every week in the announcements, you're going to see either week one information, or this week was NUR 203, right? Pediatric nursing. Um, Under that, it showed you what we're going to do this week, the chapters. It shows you any handouts that we give. It also shows you any assignments. This week, the only assignment that you have is number one, sign into Canvas and do those little quizzes that are there so you can access your information, but also a discussion question. Now, discussion questions are first done by Wednesday at 11:59 p.m. Eastern Time. So that should be the initial one. You're going to see us, either Professor Harbor or me, go in and write a comment on a couple of you every single discussion question, like 4 people. Every single discussion question. We'll go in and we're going to elicit another response, or make you think a little more. And let me give you the example of week one discussion question. Week one discussion question is 2 parts. One, who are you? Why do you want to be a nurse? The second part is about nutrition. So I might ask a question like, if you didn't get proper nutrition, how would you know that? How would a child show you that? And we know that if you don't fill up the gas tank, it's not going to get up and go, go, go. Cognitively, they're going to be behind. The growth, development, the height, the weight, it's all not going to be where it needs to be. So again, eliciting a response and then for you to respond to that, okay? So that's with discussion questions. After every class, you're going to get a week one recording or recording from week one, whichever way it's said. You're going to have the recording from tonight, and you're going to have any handouts that I think you might need, or a repeat of what I've already put in week one, so that you have the PowerPoints. You have that week one matching is an amazing back and forth concept thing. If you can answer that, you're doing really good. Okay. It helps with quizzes. It helps with exams. And everything we do builds up to it's good for the HESI and NCLEX. We try to infuse the concepts you need to help you through. I have been working for almost 10 years. I'm building this program, making PowerPoints, building Kahoots so that they're there and these handouts that we do in order to help you succeed. These are all tools for you that we've done, so use them. They do work, okay? So tonight, what are we going to do? We are going to be doing a PowerPoint about the rules and regulations of online nursing and what our expectations from you are. If I don't tell you, how are you going to know? All right. And the second thing we're going to do is this week's PowerPoint, which is chapters 26 through 30. Now, I do a PowerPoint, but I'm not going to bore you and read. You'll understand as I go. I give you the concept of the PowerPoint's got all the details you need to know. You can go back and study. I'm going to give you what it means. an overview. I don't read it, okay? So that's going to help you with understanding. The cahoots will be to follow. That'll be the last thing we do. There's only one cahoots this week, but starting next week, after every chapter, I do a cahoots. I used to do a PowerPoint, all of it, and then do all of the cahoots at once. And you get lost. You forget what I talked about in that first chapter, so you get everything mixed. So I found through a student recommendation to split it up. Have a PowerPoint, just one chapter, and then give me a test right away, that cahoots. Let me test those concepts. Do I know it? Or what do I need to really look at? Because I'm getting this confused. So it's there to help you as a guide. I know since I switched those cahoots up to after every chapter as a student recommended, grades have gotten better. So I know that the understanding has improved because of it, okay? Cahoots you can share with anybody. I don't care. They're public. You have another student and that's not my class. I don't care. They can use my cahoots. They also can have access to my YouTube channel. It is public for anybody in the world. Okay. It is Professor Bogart Pediatric Nursing. It's a YouTube channel. You've seen it. I can put down the link there, but it's just as easy. Go to YouTube, Professor Bogart, and it'll be there. There's about 6 years, 7 years of information. But what it does, there's dosage calculation. Anybody who needs help with math, I'm your guru. I can make you understand it easily, okay? Every exam in every course has 5 questions or 10 points related to math. You should not get any of those wrong, okay? And I know some of you hate math. That's okay. I can help even those who really have a hard time with math and make it understandable. Let me know, send me a message, and I will help you, okay? All right, let's start out now with our orientation PowerPoint. Then we're going to go to our this week's and to the Kahoot. Now I have a question. I can give you a break in between, or I can let you out about 20, 25 minutes early because you didn't get a break, and you get 10 minutes per hour for break. That's what policy says. So do you want to leave early or do you want to break tonight?
Leave early.
Leave
Early.
That's
Leave
easy.
early.
All right, we got it. If I have to get up and go to the ladies' room, I'll let you know. But usually I can hold it pretty good till the end. And we'll get you to the end. That will give you a little bit of time. Some of you go to community after this, correct? So you need that little bit of break to reset, have dinner, say hello to the kids, and do all that sort of stuff. Okay, wonderful. I get you. We'll work with you for sure. All right, let's just go to the orientation PowerPoint. And what I want you to understand is this is talking about the rules. This is requirements. This is expectations. Now, we're all slightly different as professors, but there's rules that are set in stone that we can't break. So I'm going to be going over those things with you. So online learning, we know it's on the computer, so you have to have a good computer, good access, and you need to make sure that you are active in searching and understanding what are your assignments due this week? When is my quizzes going to be? When are my exams? And we're going to be going over this as we go. Now, if you need any help, all of you are to go to Professor Harbor first. I will always be here. I'm not going anywhere, okay? Go to her, see if whatever you need. Any questions? I can't this and that. This is frustrating. Do you know about la, 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 la? You ask her, if she asks me, she's learning, you're learning. I'm taking care of the situation. And again, you're getting what you need, okay? If she can't help you and she's not answering you, please come to me first. If she's not answering you, I will answer your question as long as you're following chain of command. And then if I'm not going to answer you, which is very unusual, but if I don't, please, will you contact my dean, which is Professor Shed, okay? This is her email down here, joanna.chet@fortiscollege.edu. Of course, here is my email. You can email me, send a message in Canvas, or let's say that you have 1 hour to get homework done because your lives are a little busy. 3 courses, working full time, families, and all the other responsibilities that are involved with it. If you're sitting down for an hour to do homework and you have a question, if you don't get that answer to that question, you've wasted that hour. So you want to make sure that you have somebody you can reach out to. This is my cell phone. You can send me a text message. I usually don't answer phone calls. I get too many spam stuffs. So send me a text message and I will answer you and whatever you need. That's what my cell phone is for. When you need immediate understanding, not just a text, because you can send me a message, you can send Professor Harbor a message. I answer things quickly. I'm always on a computer or checking my phone, making sure I'm checking messages. So you'll get, what you need actually pretty quick. When you communicate, of course, always be courteous. Always be considerate of people. I like to treat people like the way you want to be treated. And again, they're saying no big capital letters. It looks like you're yelling at me. I only use capital letters when it's important. Like when I'm telling you, important, you're coming to this Zoom tonight. That would be a capital letter thing. Besides that, please just be courteous. It's like I'm going to treat you courteous. Treat me courteous. Academic integrity. Now we know we're online. We know they have abilities to sneak or cheat or do things like that. I request that you do your work the best you can. Not every nurse needs to be an A nurse, okay? I am not an A nurse graduating nursing school. I barely made it through, but I did it on my own. I didn't cheat. I didn't do anything extra, but I made it through and I became an amazing nurse, okay? You don't have to be that A nurse. And cheating, what does that do to you? It basically gets you through, gets you your grade. But what if you have a patient and this stuff is going on and you'd have no idea and understanding what's happening because you cheated on that exam, that quiz, that something? Again, please do your own work, all right? I would prefer somebody struggling. I will help you. Come with me, tutor with me. I will get you through this course. But the one thing, no cheating, no plagiarizing. Do the best job you can do. You, not somebody else. We know this is a professional organization. Will be registered professional nurses. That's what's on your license. So let's be professional. There are some sites out there, and we found them. Fortis knows all about them, and they're always searching for more. So be careful. The one that's been used a lot is Sudoku, Course Hero, Stuvia, and there's many, many more. But students have gotten information off that and try to turn it in as their own. Number one, it's going to be flagged as plagiarized. But number two, a lot of that information is inaccurate. So you are learning inaccurate information. So again, do your own work. It's better to do that. And I will help you if you're struggling. Now, homework. Homework is what everybody calls the busy work, but it is due Sunday, 11:59 p.m. Eastern Time. If, for instance, you can't get it done, something happened, you're sick, your kid's sick, you're in a car accident, you were evicted, you had to go to court, this happened, that happened. I have heard it all, trust me. Let me know before it is due, okay? If I know before it is due, I will give you another week to turn it in. And if you let me know, I will deduct 10 points from there, that 10%, okay? If you don't tell me anything, you're going to have that deduction. After 2 weeks, you cannot turn it in again. So if something on week 1, Week 3, it's gone. You cannot do it again. Even if it will help you pass the course, it's gone. I can't let you do it. Attendance. Well, we know there's a lot about attendance. You're doing all these swipe-ins and all this stuff on the campuses now. The thing about attendance in online is you need to be here on time. 1 minute after is 15 minutes late. I have figured it out that if you were late every class by 15 minutes, you would be over 10% late. 10% of missing attendance. That's 15 minutes of class only, whether you leave early or you come in late. So be very careful. 2 missed classes in a 15 minutes, 20%, and you will get deducted that letter grade. So be careful. That's one way of attendance. The second way that you have to maintain is you need to post onto Canvas 2 times every week. This week, what are you doing? Well, you are doing number 1, your discussion question, your initial post. That's your first time you have posted in Canvas. The second time is peer responses. So you have 2 posts. Make sure you have 2 posts every week. Now, a lot of you like to do, quote, the busy work, get it done. You cannot do sim charts ahead of time. Don't ask. You must do them on the weeks that are asked. I leave discussion questions open and NCLEX questions open for you. You can do them, but I highly suggest do not turn them in until the weeks that they are due to make sure that you're having 2 places of contact of entering in Canvas per week and attending the class. Do you all understand that? So entering into Canvas and coming to class. If you miss 2 days, that means 2 weeks in a row, you miss class and you didn't call us and we don't know what's going on, you will be dropped. Again, talking, communicating before things happen. I can help you. Professor Harbor can help you, but we can't help you afterwards. We already know about attendance and all of that good stuff. You will be receiving all sorts of messages if you're getting too high on that. Now, to be successful, you need to make sure you're doing your work. We make it easy. We have our announcements. Week 1 announcement, you know what you need to get done. Week 2 announcement, you need to know what gets done. Another thing I want to tell you is we do not put a lot of announcements in your Canvas shell. There are some professors that are announcement happy. And it's like you get to the point where you don't even want to read the announcements because there's too many. If you see an announcement from Professor Harbor or I, they're important because we don't overuse that at all. Okay. So if you see something, please pay attention. Again, you got to go in Canvas, make sure you know what's going on. As I said, you've got to have a good computer. You've got to have a good charger to make sure you can get your stuff done on time. When you start in the Canvas shell, make sure you do the quizzes, go over it, look at the syllabus. Some type of you print it, some of you do an electronic copy, whatever you want, just have your stuff there and have it available and you know what's going to be coming next. This is a really very confusing term because of the 3 courses. So again, just try to know that syllabus will always be, your guideline of what is due in the online programs for sure, your community and your pediatrics. I know MedSurg 2 makes some little bit of adjustments and changes because of whatever, but you know that peds community will always follow their syllabuses. Now, we don't do per se weekly reviews. What we tell you is this: if you need help, we'll come to class early, we'll stay class late, or you can make an appointment to see us so we can help you understand things that you're not getting. Any re-entry or any repeat student, please contact Professor Harbor because we need to meet with you weekly. It is part of the requirements, okay? Especially for re-entry. I don't want any re-entry to fail this course. So you really need to let me know what's going on, Professor Harbor, so that we can help you, all right? And we're willing to do that for you. We know that tutoring helps, period, because you're understanding concepts better. Now, there's two components of grading here. There's the KGA, which is your key graded assignments, which is your exams, quizzes, and essay. That's 20%. You have to have a 78.0 in order to add in your homework grades. And then you need a 78.0 with the combined in order to pass this class. So one thing I highly suggest in the homework, make sure you have a 78 on everything. I can't tell you how many times a student will tell me, I don't know, I passed KGA, but I don't know my homework. I don't know if it's going to fail me. Well, if you got a 78 on everything, it won't fail you. It'll keep you passing, okay? So only turn in passing homeworks because once it's turned in, you can't return it in later on for a better grade. Homework grades we turn on and off, and we do that to show you how they can affect your grade. Weeks 1 through 5, they're off. There's really not any homework to look at that will look at the scores. Furthermore, your first exam is week 4, so we don't really have a lot of stuff to do before then. On week 8, on week 6, we turn on the grades to show you the KGA with homework and the exam and the 2 quizzes by then you'll have. All right, it'll show you how it all is affected. Now, week 8, we turn them off. I cannot turn them on again until all the grades are in, and that is your final grade. After HESI remediation is all in, and then I've checked everything, then I turn homework grades on, and that is your final grade. When you're taking exams and quizzes, now, many people for quizzes, some of the professors have you come in on a phone. I don't do that. What I do is I have you come in on your computers, and then I do my check that way, okay? I want you to know that every click, every touch of the computer, we can see in quizzes and exams. So we know if you've gone off page, and we know all that stuff, all right? So be careful. Just do your own work with it. When you come with exams and quizzes, make sure that your equipment is plugged in and working properly. I highly, highly suggest you do all of those practice exams in Exemplify, the ExamSoft. And the reason is this. I've had many students have issues the day of the first exam, and they did the practice exam. So they gave them a free out. We could do the exam at another time. It wasn't their fault because they tried, they did the practice. And then I've had students who didn't do a practice exam, had a problem with the exam, and we had to give them a minus 10% deduction. So you see, doing the practice ExamSoft exam is very important, okay? So that should be up, I think, by end of week 2. We're going to be having ExamSoft will be available. We'll have those practice exams for you. Another thing, during exams, let's say all of a sudden your computer went black, your internet went out, whatever happens, okay? You're like, oh, I'm not done with my exam. What do I do now? Oh my goodness, the exam's lost. What's happening? Well, I want to assure you, this exam is not lost. Once something happens and you can't access your exam or your quiz, you need to contact Professor Harbor immediately, okay? We can go back and look at when you sent that message that exam stopped working, whatever happened, and we can look at the exam and see when you last touched a stroke on any key, match the times and say, yes, this is what happened. And we can get that exam restarted at the same place. You're not going to lose any questions you've already done. You'll just be starting from where you stopped, okay? When you are uploading your exams in the end, sometimes they don't upload right away. Don't worry. Your exam will never be lost. There's ways to go back. So take a breath. This is one of the biggest fears I think I've seen students. Oh my God, my exam's lost. What am I going to do? I'm like, it's okay. You still have your exam. I've gone back 2 weeks later and found exams. So it's not a problem. I work with ExamSoft well. Remember, during exams and quizzes, they both must be proctored. Face completely on camera is a big deal. The first quiz will be on Canvas next week. It's 10 questions. After that, so week 3 and onwards, for those quizzes, it's going to be in Canvas, but on SharePoint within Canvas, okay? It'll be 25 questions, and it's going to test your knowledge. Now, why am I mentioning this? Quiz 1 is going to be on this week's information. Quiz 2 is going to be on week 3 when you get it, that information. And week 3 information is school age and adolescent children. So you have to come to class prepared for quizzes. The first quiz, you get it all this week. You listen to me, you watch, look at the PowerPoint, look at the Kahoots. You're good for your quiz, okay? When it starts with quiz 2, 3, 4, 5, you must come to class prepared because it is on that week's information. Quizzes can't be made up any reason, okay? Now, if one quiz, because you were sick, you have an excuse, you have documentation, you were in the hospital, you went to the courts, you had an accident, whatever happened, you have documentation and you have one quiz. If you take it and pass it, you'll pass. If you do an appeal, and I'll help you with it, you can retake that quiz and possibly pass the course. That's the only time. So if you're ever late for attendance, please get documentation if you can. And this is just showing you where it's at. Exams are in ExamSoft. You have to download your Exemplify. You need to come in with a phone. Make sure you have chargers. Things are charged. I can't tell you how many times, oh, I got to go get a charger out of my car. It should be there, ready to go. Your equipment for nursing. When you walk to work, you need your stethoscope, your pen, your this, your that. When you walk in, your uniform on, your nursing shoes on, right? You need everything. So again, come to class prepared. Make sure you have an ID, whether school ID or driver's license. I've even looked at passports before. And make sure, again, your face is there at all times. Exams, only one time you can take them. Now, what happens if you go and you didn't do well on exam 2 because you came to class and you weren't feeling well, you had a migraine, you had a GI problem, you were sick, you had the flu, whatever, and you didn't tell me, and you said, I'm just going to take that exam, and then you bombed it. You get a 56 on it. You're like, I need to redo that because I wasn't in my right mind. What I'm going to tell you is this. If you're sick and you're unable to take an exam, as long as it's not every exam, if it's one exam, tell us. We can delay your exam up to 1 week, okay? But you have to tell us before the exam is due. If you just don't show up for an exam and don't take it, yes, you can still take the exam, up to the next class, but it's a minus 10% deduction. Isn't it better to tell me you're sick and not take it now and do it at another time? And we'll work out the time that works for you and me. Okay. And you and Professor Harbor will work with you instead of being there being sick, vomiting in a bag as you're taking an exam. I've seen it happen. Don't do it. If you're sick, don't do it. Make sure you're at the best possible way that you can be. Now, you've seen a posting about accommodations. Anybody who has accommodations, extra time, quiet space, whatever it is, we need these letters by tomorrow night, midnight, because it won't be in there for the first exam and your quizzes if you do not tell me. The extra time and stuff won't be there. I need the letter from Elaine Foster or your dean or whoever it is. I need that letter by Friday night, or Professor Harbor. We need it in order for you to get that, what your just due is. I mean, we want you to get what you need, okay? Another thing is sometimes some of the campuses will the students like to do their exams on campus. I don't have a problem with that, but there's a couple things that has to be done in order to do it. Number one, I need you to notify me, you as a student, before 72 hours. 72 hours before the exam, it's too late. So notify me before then. You notify me, tell me when you're taking it and who the proctor on campus is. And you need the proctor email me. So it's two people email me, let me know. I will make an exam for you and I will send the proctor the access code. So there's no delay in you taking your exam. It should be at the same time, same day as class, if possible. Okay? So that's proctoring on ground. I do teach after exams. So this is a class starts at 5:30. So 7 o'clock, you need to be back after exams to take class. And we will teach class after class until we're done. Okay? We know exams are all proctored, no hats on the head unless it's a religious thing. And then you need, for us to know that, before exams, nothing in the ears, and we check all those things, 360, ID, et cetera, et cetera. Again, tell me before, don't tell me after, I can't help you. And all exams have to be made up within 1 week before the next exam. If, again, you're having problems with exams, stop immediately. Let me know. We can restart it at another time. It's not going to be another exam. It's the same one. It'll just continue. So just stop. Your HESI exam is one attempt, and you do have 20% of your grade. And we know there's that personalized learning plan at the end. As long as you're 100%, got to check. You've got it done. Again, you've got to get that HESI remediation in by week 12, Monday at 11:59 p.m. Eastern time. And that will allow us to put your HESI grade in. If you don't do remediation, you do get a 0. I've seen it happen. Any problems, let me know. Homework. We've talked about it. Keep yourself organized. I told you it's going to be in your announcements. We know you got 1 week to turn it in. If you can't, let me know. And you'll get another week without deduction. Or if you don't tell me anything, you're going to get a minus 10% deduction. The NCLEX questions. The first set of NCLEX questions is not pediatrics. It is growth and development. Be careful. You try to do growth and development on pediatrics, there will not be enough questions. It's a different topic. So you have med-surg, you have pediatrics, there's a growth and development one too. And you check infants, toddlers, preschool, school age, adolescents, and it will bring up your 50 questions. If you do not do the proper set of NCLEX questions, you'll get a 0. But in the comments will be written, please submit growth and development by Sunday, and you will not receive a deduction. If you don't turn it in, you get a 0. So again, we will work with you, but please pay attention to these sort of things. Make sure your NCLEX questions are a 78 or higher. Your NCLEX questions are 5% of your grade, so make sure you do that. There is a HESI assignment and practice exam. Again, it's through Canvas. This is right before the HESI, week 8 and week 10. Again, these are good to do and do them properly right before your HESI. Your sim charts, as I said, they're not going to open until when they're due. Week 5 is your first one. And that first one is respiratory. So that is week 5. I don't open them early. I want you to have them as they are due, okay? It helps you understand the information. Another thing I've seen with sim charts, students like to go right to the quiz in the end and just answer the questions. The problem with sim charts is they're going to ask information that you would only know if you read the chart. Like how tall was the patient? How much did they weigh? Or something of that sort. You have to have read the chart. So take your time with them. They actually are trying to help you think about these concepts. Your paper, week 8, is a pediatric assessment assignment. This assignment is 6% of your homework grade. The first portion is a little paper, 250 words APA. Tell me what that condition, that assessment that you picked. You can choose any pediatric diagnosis you want. In module 8, you're going to see a whole list of stuff. You don't have to use it. This is there as if you have nothing else to choose from. I've given you some choices, 30 some odd, or there's quite a few there. What I want you to choose, something you had, your child had, your next door neighbor, a friend, some diagnosis you've seen and it interests you. This is what I want you to choose. I have parents with children with autism. They do their thing on autism. It helps you learn, understand more. Once you get your diagnosis, you must get it approved through Professor Harbor. So make sure you said, hey, I want to do autism, or hey, I want to do asthma, or hey, I want to do whatever it is, okay? And we will tell you yes or no. We cannot have 10 autisms. We want to have a little bit of everything. And I always say, challenge me, find me something I don't know about and teach me something. I had a couple of them last term, and it was great to see these different things I've never seen and learn about. The second portion is a pediatric assessment. It's a printout. And the third portion is a teach me something. So if I was teaching about autism, maybe I would teach about the therapies that they might need, or teaching them medications or anything. I tell you, I don't need a 20 slide PowerPoint. No, maybe 5 slides. Teach me something about something very easily, precisely. Teach me, teach a nurse, teach a child, teach the parent, teach something about that diagnosis, and make sure that you do have references on the end of there. Yes, you taught, but you need to know who taught you how to teach that, right? Again, there's a rubric. If you need help with writing papers or whatnot, send me the paper early and I can help you. I mean, many of you will go on for your higher level degrees. And when you get on to your BSN and upwards, it's no more doing tests and knowledge. It's all about papers and PowerPoints and expressing yourself. So again, if I can give you a paper that's perfect APA format, you're going to have that as you go forward in your education. So Any questions so far? Okay. Gwendolyn, are you there? I don't see a head. Oh, there you are. You were hidden back there. Thank you. You moved. Let's go ahead and do this week. Can you see the PowerPoint?
Yes.
Thank you. So, pediatric nursing. This is chapters 26 through 30. A lot of information, but it's not super specific. It's like a global beginning understanding of pediatrics. So, let's start with this. So, healthcare for children. When I went back to my BSN, my MSN, I found out there's this program called Healthy People. I mean, when I started, it was 2010, okay? But Healthy People, what is it? What it is, it's a government program that looks at healthcare disparities, whether they're children, because yes, they're vulnerable populations, right? Or we look at the elderly or the homeless or something, and then we look at things focused to the children that we want to address closely. I mean, let's look at healthcare for children, nutrition. Didn't a lot of stuff come out about school lunches and the changes in diets and all those things? Yeah, it's because of healthy people. Another thing, remember Obama talking about getting up? Michelle Obama's get up, get outside, exercise, don't be inside on your computers 30 minutes a day. Isn't that all about physical activity? And it has to do with being the proper weight and healthy with all that activity and stuff, right? So that's what Healthy People is. It is a wealth of knowledge for papers as you get higher up in your degrees, also, just to let you know. So, healthcare for kids. Some of the health problems, the biggest ones that are out there. Number one is obesity. You know, children today are not up and out and playing outside like they used to. There's many reasons. It could be because the neighborhood's not good and they're not safe. Or it could be because kids come home and are on the TV, on their iPads and computers and playing games, and they don't want to get up and go outside and play anymore. They're too busy, you know, with their games. So what do? They sit, they snack, they get heavier, they're not exercising, and then they become obese. Obese school age children have a tendency to become adults with diabetes, heart problems, right? High blood pressure, cholesterol problems because they were overweight as school age children. And that's usually when we will address it and try to teach. School age children are the perfect group to teach about many things. And one of them is diet and eating properly. Childhood injuries, I mean, they happen all the time, right? I mean, motor vehicles are going to be the number one highest on childhood injuries. Violence, vaping, we know it's there. And mental health problems. Do you think kids have mental health issues? They do. And I've seen some really severe ones. I still remember this little 6-year-old boy. He was a schizophrenia. He was paranoid schizophrenia. Oh my God, that poor little boy. He was so lost in his head. He was so scared. And it's really frightening, even to watch that poor kid it was. Still remember him. Now, infant mortality. The World Health Organization looks at this. Now, United States is not high on saving kids, you know, lower death rate levels. No. There's other countries, Scandinavia, you know, that area, Norway, Sweden, those areas actually have better infant mortality numbers. Now, we measure them by 1,000 live births. You know, that's what they look at. How many percentage? That's what they look at. Now, there's something called neonatal As I said, first 28 days of life, they are a neonate. Well, think about neonatal ICU, NICU. That's the itsy bitsy babies. Think about neonate. This is ages 1 to 28. After that, up to their 1 year old, they are an infant. You're going to hear those words interchangeably, neonate and infant. Neonate, your younger infant, okay? We know that infant mortality, a lot of it has to do with their birth weight. How big were they at birth? How mature were they? Death rates for children greater than 1 year of age do uh, are less than infants. Just think about this. Infants don't have an immune system. You know, they're born. We don't know what's going on with them. All of these things could occur and could happen with them. So again, infants will be higher. Their immune system settles up, and then infants, toddlers, have less of a birth rate. And that makes sense, doesn't it? Because your infants are more susceptible. Toddlers are getting a little bit stronger. When by the time we get to be school age, that 4 to, well, young adolescents, 12 to 14, that's when the lowest is. They've got their immune systems, they're smart, they try to please, they're pleasing, they're adults. This is part of school age people, so their rates slow down. But by the time they get to be an adolescent, I'm an adult now. I can do what I want. Injuries, think about now, what do adolescents do? They get their driver's license. Now they're driving. So now, again, motor vehicle. And of course, all injuries, because sports injuries are trying to overperform, to be the best, to get the scholarships. Injuries, injuries, injuries. Homicide, they're picking up the guns and they're getting into gangs and violence, and that. It's part of it. And then the second most thing that goes on with adolescents is suicide. Think about adolescence and think about you as that young adolescent. You were all about, I'm too fat, I'm too skinny, I have too many freckles, too many pimples, I've got too big feet, I don't have this. It's body image. It's what you feel about yourself. And when you don't feel good about yourself, you're going to be depressed. And depression leads to suicide. So those specific areas which have an increased risk for death are, again, that low birth weight. That's always going to be there. These kids have to go through a lot in order to be able to live with low birth weight. But homeless and poverty, if you're always sick, foreign born, a lot of foreign born come over with TB. It's one of the things that we look out for. And then, why do children in daycare centers have an increased illnesses, morbidity? Think about it. What do kids do all day long? They play. How do they play and explore the world? In their mouths. What do kids do with toys? They play with them and then they put them in their mouths. Their shirt in their mouth, their pen in their mouth, this in the mouth, everything in their mouth. And then what do? We share them with other kids. Children in daycare swap spit all day long. And that makes illness go around and around and around. That's why it's increased. Does that make sense now? So pediatric is all about not just the kid, it's about the parents too. And this is probably why many nurses do not want to go into pediatrics, because parents can be a little bit much. Well, what I've learned is I teach my parents and I put them to work. And they're my eyes and my ears, and they're the voice of that child to let me know if something is going wrong. So they can be your advocate, your best friend, or your worst enemy. So teach them. Let them know what's going on with their child. That's all they want. They're scared to death. Their kid is sick. So if you can teach them and put them to work, that's all they want, okay? Remember, the family is the only constant in a child's life. Think about that for a second. The only constant, it's all they know. They only know the holidays the way the family does it. They only know bedtime the way their family does it. They know family food the way the family does it. Only know the family until they get older and get out of the house, right? Family's the only constant. It's what they need. It's what they look at. It's their comfort. The other thing about nursing and children is not hurting them. Atraumatic care. Now you go into the adult ER and you get an IV and you stick it in someone and they stick an 18 gauge in you and it hurts and they put it in and they don't put any numbing cream. They don't help you. They don't even hold your hand, right? It's like, here, deal with it. Boom. Well, you can't do that to a child. So we do everything to decrease the amount of stress, pain, and fear of children. I developed a program which is still being used at our area pediatric hospital at Nicholas Children's. Okay. It's something called Huggies, and it's H period U period G period. It's an acronym. And what it is, it stands for, it's research I did doing my PhD. It's help us give great injections efficiently and safely. You can Google it, you'll see it. And what it says is that a child, any age, that's being held by the parents before, during, and after a procedure, whether an injection, IV, suturing, we've done all sorts of things in the parent's arms, that this child had less pain, fear, and stress before, during, and after, as evidenced by less crying. Amazing, isn't it? Just by holding your kid. And it's something that should be done. Isn't that where a kid wants to be? With mommy? So let them be. As long as mommy is there holding them. Always have the second nurse to hold the leg, the arm, the whatever, yes. But at least they're in mommy's arms. Because once the injection's given or they're done, they're there being hugged by mommy. What's better than that, right? That's what pediatric nursing is about. To do no harm, to minimize that physical and psychological distress.
Betty,
Yes.
are your slides supposed to be progressing? Because
Yes.
I do not see them. I don't know if anyone else can. I'm still on.
Anybody see it moving?
No, I can't see them either.
Oh,
I just see the first page.
Okay. Thank you. Do you see the role of, okay.
Yes.
yes. Thank you.
Okay. Now, let me see. Did that page change? It changed?
Yes.
Okay,
Yes.
thank you so much.
Yes.
Thank you so, I appreciate. I don't know why it didn't. But anyway, we'll continue. So, nursing. You know, as an adult nurse, you take care of your patient and maybe the family, but it's not as much as a nurse. You are their advocate. You are their counselor. You're the psychiatrist. You're the everything for the family and for the child, and you're trying to get that child the best care they can, okay, through evidence and research and all that good stuff, which is what I did, the research on the holding. So, the leading cause of death among African American boys ages 15 to 19 years is what? Adolescents, boys.
Suicide or
C.
firearm homicide.
Firearms. Firearms. It's firearms. That is a leading cause. I think to follow would be maybe suicide, but it's definitely the firearms. Thank you. All right, now let's look at some sort of cultural and all that sort of stuff. We're going to go continuing more. Family. Family is important, isn't it? And the structure of it. Now, a family, what is it? What's my family? What's your family? They're all different. But the family is whatever they say their family is. Sometimes you have 3 generations in a household. That's their family. Sometimes you have a single parent and a grandparent and a kid. That's their family. You can have two men, two women, adoptive, they're family, 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 family. There are all sorts of blended families, et cetera, et cetera. Again, a family is whatever they say it is. And that's all the different ones it could be. We know family is strong, and we know that every family, they can help you. And we know that just like all of us, we have strengths, we have weaknesses. And if we can use that family strength to help that child, which actually helps us do our job, and we're teaching them, so these kids are going home with parents who are understanding. But we as nurses, as I said, we do more than just nursing care. We've got to figure out who is the charge of that family. Is it the grandma? In South Florida, it would be abuela. The grandma would be in charge of everything. But it might be the aunt who's in charge. Might be the mother, the father. You don't know. Find out what's their role, who's in lead, because you need to get information. So again, figuring that out. Another thing we look at is types of parenting skills. We have some parents that let kids do everything and some kids that are strict. Some kids that want to be the parents, the parents want to be the kids' best friends. I mean, again, all types doesn't make it right or wrong. It's just what it is. We know that there's adopted children, et cetera, and there's issues that have to do with that also. Divorce is a big thing with kids and how it affects them and being back and forth. I mean, we all understand that. I mean, I had to deal with it with my children when they were small. So part of also being a nurse is understanding your child, your family, and the culture and the way they are. And I've always learned that if I don't understand, it's better that I ask the parent or an older child about something. If I don't understand, it's okay. You don't have to know. You don't have to agree with everything you hear. Okay. Your religion, your culture, your beliefs are yours. You just have to know that. You, though, have to understand this child's family so that you can deliver better care to them, as in respect, right? For instance, there's a question that's going to come up about some cultures that won't look at you in the eye because they think it's a lack of respect if they stare you in the eye. There's cultures you can't touch. There's little space that you can't enter, right? I'm a hugger. I always want to hug everybody. There's some cultures I've got to learn that you don't do that. And it's the father you speak to. It's not the mother. There's all things. And how do you learn that? You learn it through time, but also asking lots and lots and lots of questions. So a frequent health problem of migrant children and adolescents in the United States is what? And I tell you is the big issue with that.
Is it tuberculosis?
It is. It's tuberculosis, yes. I mean, we basically wiped it out in this country, but it doesn't mean it is in all countries. So let's look at health promotion, kids growing. So think about that infant again. That infant was born at 7 pounds. At 6 months, they double their weight. They're 14 pounds. Not only that, they gain 1 inch per month for the first 6 months. Can you imagine? They double their weight and 6 inches they grow. It's incredible how quick. This is the quickest they'll ever grow in their whole life. And then at 1 year, they triple their birth weight. And now they're standing up on their feet and almost walking. They can't lift their head at birth. And now they're walking at 1 year old. It's what this growth and development is, that interrelated, simultaneous, and ongoing. And it moves forward. Now, this is something interesting that just happened to me. I've got a 14-month-old grandson, and this little child never crawled. He lays on the floor and sort of scoochies and pulls and wiggles, but the knees aren't up and he doesn't do the crawl. But he's up and walking all over the place, holding on to stuff. Smart as a whip. Now, does that mean he's behind growth and development? No, because he's moving forward. That's what we need to look at as nurses. Growth and development. Are they moving forward in the growth and development? Now, there are different words. We have directional trends as we get grower and bigger. Sequential. First thing a baby does is lift their head. That's a growth motor skill. First thing they do with their hands is a reflex, palmar grasp. Okay? These are things that happen first. Second thing, they lift their head. Now they're rolling over. Then they're crawling, they're creeping, they're walking. Their hands, they have a reflex palmar grasp. Now they have a voluntary, I grasp that right on myself. And then you put them in a high chair and they went to eat. Then they have a crude, what they call a pincer grasp. This is a pincer grasp, the thumb and the finger. But as little kids, it's like a smush in the face, called a crude pincer grasp. So fine motor, gross motor, there's a sequence that you follow. Developmental pace is just when you are turning over and when you're sitting unsupported, when you're walking. And sensitive periods are those really important times where they really learn a lot. Okay, that's sensitive periods. Now, at birth, I said in neonates, heart rate is 140 to 160. That's their metabolism. By 1 year old, their heart rate could be 100 to 120, and that's normal. So metabolism, again, I've sent you a handout. I'll repost it again, but it's basically giving you, don't look at the exact numbers. It is showing you, you go, heart rate's high, it comes down as you get older. Blood pressure starts lower and goes higher. It's just you understanding where about a heart rate might be. What if you have to give digoxin to a 2-year-old? What's a normal heart rate? You see, now you understand why you should know somewhere maybe a heart rate be. Or a 1-year-old comes in, he's breathing 50 times a minute. Is that good or is that bad? You see, you've got to know a little bit of numbers, okay? And we know a 1-year-old breathing 50, they're in respiratory distress. It should be less than 30, guaranteed. We know at birth, kids do not regulate their own temperature. They come out and they're wet. We got to dry them off vigorously, put a hat on their head, put them underneath a warmer and warm them up because initially they do not regulate their temperature. And cold is not good. There's many things that happen to a baby who are in cold stress, so we don't do that. Sleep and rest. We know younger kids sleep more as they, as they're younger, less when they get older. And nutrition, 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 the single most important influence on growth. If you don't put gasoline in the tank, guess what? You ain't going to go. You're not going to grow and you're not going to think. Cognitively, you're going to be behind. Growth, you're not going to be where you need to be. That is probably one of the biggest reasons why we do height and weight at every single visit that you see a child. Not with adults. I can lie forever. I'll be 210 pounds forever. I'm a little more than that. Anyway, children and parents. We know that there's all different types of kids. My little 14-month-old grandson is the easiest, mellowest kid you'll ever meet. Okay? Not a problem. But my son was the hardest child that I've ever worked with. Very difficult, stubborn little child. And then we have some kids, like one of my daughter's little nephews from her husband. That kid did not warm up. It took a long time. And kids usually jump in my lap. Long time to come up to me. They're all normal. Kids are all different. And it's normal. Now, I'm going to go into some theorists. Now, you're going to get this really more intense next week, but I want to introduce it. So, Freud. Freud is anything sexual. That's what he talks about. Oral, that's sexual, isn't it? It's all about everything in the mouth, exploring. Pacifier can calm them, right? It's all about the mouth. Anal, for a toddler, you're in potty training. Anal. Phallic, boys like mommies and girls like daddies, and they're understanding there's boys and girl parts, right? Part of it. The only weird one is latency, and that's school-age children. And all that means is they like to be with their same-sex peers. Girls hang out with girls and boys hang out with boys. That's all that word means. I don't know why it's a bad word like that. And we know adolescent genital, they think with their genitals. We know they're getting, all right, excited at that point. Now, Erickson. This is psychosocial. What does that mean? How do people affect a child? What does that child do with that person? And let's just do the first one, trust versus mistrust at birth. What does a newborn, an infant, how do they trust? Well, when they cry, a person goes in, picks them up, changes them, feeds them, burps them, holds them, and now they're happy. That is trust. What is mistrust? There are times where, whether it's with drug abuse or alcoholism or homelessness or those sort of things, where a child cries, this infant's crying, and nobody on at all the time, not once, but all the time, don't pick up that infant, these infants start to mistrust. These are actually infants that stop crying, and they wouldn't even look at you. They're like sit there in wet diapers, and it's like, this is what's expected, and they just sit there. And it's really sort of sad. So trust, because that person comes, picks me up. We're going to go into the rest as we get into those groups. I'm not going any further with that right now. Piaget. Piaget is all about thinking. So let's go back. At birth, a baby can't breathe. So we spank their butt and they go, oh, and then they start to breathe, right? Then we take a nipple or a breast and put it in the mouth, and now we're swallowing and breathing. They had to learn that, right? They learned from starting somewhere. That reflex palmar grasp got them using their hand. It was a reflex, though. Eventually, they learned, hey, there's a rattle there. I want it. And they grab it, right? So that was now voluntary. Now that rattle moved and it made a noise. Oh, I like it. So every time they get the rattle, they make the noise. But then, oh, I put it in the mouth because, you know, they explore everything in their mouth. So now they've learned from a reflex to a voluntary to sucking on a rattle. It's a progression of learning. That's what that is. And it's all about sensorimotor. The first 2 years of life are all about the feel, the sense, the touch, the smell, the sight, okay? And then oral, ori, mouth, everything explored in the mouth. And motor, taking that block, moving it like a car, moving things around. Sensorimotor. It's the first 2 years of life where they're exploring and figuring things out. As we go farther, it's more complicated. Babies that are born, we know how to cry and we know how to coo. That's the communication. And then the other theorist you need to know is Kohlberg. Now, Kohlberg is all about morality, which is right and wrong. Infants and toddlers do not know right and wrong. They're still learning. Preschoolers, what is their concept? That's the first people who understand right and wrong. Preschoolers understand that there's right and wrong and a consequence for each. That's what they understand. That's preschooler. As we get up to school age, they please. They love to please. They don't want to be wrong. They like to please. They like those strokes. They like to be told they're doing good. I'm a pleaser. Okay? That's Kohlberg. We're going to go into it again, of course, more than once. So play. There's types of play, and you need to know the types of play. So we have socioaffective, which means around people. Sense pleasure. That's mashed potatoes, fingers, and smearing it everywhere at the end of a dinner, right? That's sand. That is squishing your toes through mud. That is touch and feeling, that sort of thing. That's sense pleasure. Skill play could be like making a pile of blocks. I mean, you have to have a skill to do it. Unoccupied, alone. Dramatic or pretend could be where we figure out something that happened. It could be in a hospital. Something happened, the kid was upset for whatever reason. We can, through play, which is not threatening to this child, learn out why. Why were you upset? So we can do that with play. And of course, games all the time. So what does play do? Again, it's that touch, that feel, that mouth, the motor, sensory or motor development. That's what kids do. You ever watch them? They're feeling, they're touching, they're playing, they're in their mouth. It's just all part of that exploration. And that helps with their intelligence. It helps them understand things and be creative and all of that good stuff there. So types of play. We have when we're looking at somebody, onlooker. And then we have, of course, playing alone. Now, the next three plays, you need to know what they are. There's parallel play, which is toddlers. We have an associative play, which is preschoolers. And we have cooperative play, which is school age. And what's the difference? Well, toddlers in parallel play, they can play in the same room, parallel to each other, but they're not sharing any of their toys. Me, mine, I'm not sharing, but you can play over there next to me. That's parallel play. Associative play is preschoolers now. Preschoolers are 2 or more children playing together, but there's no goal. Nobody wins. They don't make anything. They're just playing with all the toys, having fun. That's it. And then cooperative play. This is school age. School age children, 2 or more children playing together, and there's a goal. Somebody wins. They are playing checkers. Somebody wins the game. They take in a racetrack. They put it together, and then the race car's working. It's something. There's a goal. Somebody wins. Cooperative play. That's school age. You know, toys are that thing that helps families come together and associate with that child. And it helps that child, that infant, you know, learning to crawling and using muscles and getting them stronger. And it's a great time of that bonding, that playing together. Developmental things are what we as nurses will always be looking at. You're always going to have different forms and things in any hospital you work at. Of course, always be accustomed to that. But again, going through and seeing what, where is that child? Where should they be? And assessing them. One of the most difficult children to assess is children with disabilities, like with cerebral palsy or something like that. There are special different forms for them. Again, if you're working in a hospital, find out the form and use that, quote, the special form for that child. We know genetics can affect children. I think the big one that we think with genetics, we think of Down's children, don't we? You know, Down's children are children that are born that, you know, have certain characteristics. And I know that children born with these sort of genetic syndromes, there's things we can do to make that child be the best they can be. And we do that with early intervention, which is speech therapy, occupational therapy, and physical therapy. I'll give you an example of Down syndrome that I noticed working as a clinical supervisor for some students. I was working in this pediatric prescribed daycare. It's an extended daycare. But I'm telling you, very high level of what was going on. They had infants, they had toddlers, they had the wheelchair room, and I'm telling you, all different sort of stuff that was going on. What I noticed within the first day of going in there and teaching clinicals was that children with Downs usually have a tongue that you always see. It's always there. It's just part of what you think with Downs. What I noticed, because these children were getting proper therapy, they're in prescribed pediatric extended care, right? They're getting speech therapy, occupational therapy, physical therapy, and that speech is what you do for eating and mouth stuff. Let me tell you, I didn't see tongues hanging out of these children's mouths. And it's the first thing I noticed. Like, wow, their tongues are in their mouth. And it's because early intervention. So communicating with children and assessing them. Well, one of the things with children you have to be careful with, the last 10 years, I worked in a trauma center, an ER. And the one thing that you have to be careful with is the age of the child. When a child who's cognitively aware, alert, and oriented comes to the emergency room who's 18 years old, you must have them sign their own admission sheet, and you must get permission to ask that you have get permission from them to tell the parents what the lab results, the x-ray results. I'm telling you, I've run into some sticky situations with that. 18-year-olds don't want to tell their parents, and I can't tell them. It's the 18-year-old that has that control. This is always a question on NCLEX, always about HIPAA and 18-year-olds. Now, communicating with families, okay? We have to talk to them, especially younger kids. We need to know what's going on with their kid. And also we have to, be aware of all the things about talking and listening are. So as we find out who's going to be the speaker, okay, we're going to encourage them to talk. But I don't want to hear everything from birth up to now if it's been a normal type of childhood. I want to know a focused. What are you here today for? What's been going on? And then, you find out the whole thing. I have learned that just sitting there and getting information from parents, you've really got to be aware of culture. Staring them in the eyes or touching them. Am I talking to the father, the mother, the grandmother? You've got to be aware of cultural. And if there's a problem, again, I say, don't be afraid to ask. Does this bother you, or what would you like me to do? I mean, again, it's giving them respect because you're telling them you understand, you want more from me. If you need an interpreter, you cannot use an older member in the family who speaks both languages because they're going to put their own spin, their own understanding on what is said. So again, use a proper interpreter, whether one on the phone or somebody that you work with that, speaks that language. Now, communicating with kids. How do we do this? Well, number one, you have to get down to their level. As I said, the last 10 years I worked in an ER. So the child be sitting on a stretcher. I would pull up a chair and sit actually a little bit below them. And then I would start a communication. I will start it and I will be concerned about the developmental level of the child I'm talking to. If I'm talking to a preschooler, I might pull out a sticker and give them a princess sticker. Say, look what I have for you today. I got more if we can listen to me. Now, preschooler, that's good with, but it's not going to work on an infant, right? On an infant, you might make noises or tickles or do something of the other sort. But again, according to the age, get down on their level so that child's going to understand what you're talking about. As I said, you always find out who knows what's going on. Let me know what's going on this time. I only need to know birth history if it's more than they were born and they went home in a day or two. If they were admitted, they were intubated, if they were in the ICU for a long time, that's stuff that you would need to know for birth history. What do they eat? Now, what if they're vegetarian and I'm finding a low hemoglobin hematocrit? I know dietary history is a big importance, and I might call in the dietitian to make sure they get better iron in their food. That could be a problem. Or I have a child who is lactose intolerance, and I have to make sure they have enough calcium, enough vitamin D. So again, diet makes a difference, and things you have to think about. I need to know if anything's ever happened to the kid, of course. Allergies are important. Medications, ibuprofen, acetaminophen, have they had any, so that I can continue it. And immunizations, extremely important. I want to know, especially a young infant, they have a fever, and if they have a cough, I want to know they're immunized. I don't want to spread infections to myself or any other kid. So again, knowing immunizations are important. I also want to know any habits. I want to know this is their special pacifier. This is their special blanket. There's their toy. These are things that when they're upset, these will help them calm down. These are things, those special habits I want to know about so I can be there for that kid. Older kids, you can get sexual histories from. Now, I would never talk to my parents about any of that. So I would not answer a question if my parents were in the room and a nurse was asking me those sort of things. But you can, as a nurse, have the parents leave, talk to that adolescent, find out what's going on. Are they having sex? I mean, some of these adolescents will want to know more information, let's say about birth control. Can you give them information? Yes. Oral and written information, not your opinion. Yes, you can. Now, do you have to tell the parents what they asked you or told you? No. Unless it's something that will hurt themselves or others. No, that is a confidence. One of the things that I find out with the younger kids, find out when they're like those preschoolers, early school age. So, how's school? Who's your favorite teacher? What's your favorite subject? What did you get on your last test? When they answer, you can figure out how they are alert, cognitively, etc., how adjusted they are. And it does help you with their care and how you treat them. Again, assessing children is different than adults. You don't do head to toes on children. Adults, you do the head to toe assessment, right? Like you did in health assessment. They showed you how to do it. Not in kids. If the kid came in coughing, you'd listen to the lungs first, right? If they came in and their tummy hurt, you might be, diarrhea, vomiting, you might be checking an abdomen first. Again, you get the rest when you can get it done because you want to focus first. As I said, dietary intake, cultural foods. Again, if it's something that could be affecting the child, make sure that we get the dietitian in, or make sure that they get the extra calcium if they're not on milk, et cetera, et cetera. If they're overweight, underweight, again, address it. Who do we need to tell? We might need a dietitian. We need extra sort of calories. Tell the doctor, et cetera. So physical assessments, as I said, head to toe is not what we do. Again, we're going to be doing it only focused. Toddlers, using games about body parts. Is that your heart? And point to the nose, put the stethoscope there. I mean, doing little things, making them giggle, and things that they should know a nose and a mouth and ears, a 3-4-year-old, right? So you take the things, oh, that's your heart on your nose. It might create, you're not threatening anymore. So games and funs on body parts that always do help. And that helps also. Wouldn't you want that child who's scared to be sitting on mommy's lap, the huggies position, so that they're more comfortable? And guess what? You can do a better assessment by doing that. Children know more than you think they do. And if you tell them something's not going to hurt and it does, they will never forgive you. So if something is going to hurt, you need to let them know. But you need to say you'll do everything you can to make it hurt as little as possible. Okay. Always do it at an age appropriate so they can understand what's going on. If they have to lay on their side or sit on their butt, or let them know what's going to happen so they can be prepared. So, which approach would be best to use to ensure a positive response from a toddler? You have a 1 to 3-year-old kid. What are you going to do first?
A.
You're going to assume eye level. Yes, get on their level. And then again, develop the appropriate questions, maybe teasing, playing games, giving stickers, whatever it is. Let's gain some trust from that child. So your physical assessment, we have those growth charts. Again, height and weight are so important. It tells us so much in children. We used to do apical pulses on children young to get that good thing. Know that there's different equipment for different age kids. There is a blood pressure cuff that will fit on my finger, my pinky, and take a good blood pressure. That's for your real small premature infants. And there's also the extra large one that fits on my arm. So again, there's so many blood pressure cuffs. What do I pick? You've got to figure out as a pediatric nurse which one would be the best. I usually take 2 sizes of blood pressure cuff if I'm unsure. You know, infants and children, when they're sick, they look sick. When they're well, they look well. So it's general appearance is something that we do look at. The color of skin, looking for retractions. Lymph nodes in children should be non-existent. You can't feel them unless they're sick. What do lymph nodes do? They secrete white blood cells, which help fight infection when you're sick, right? So if you're not sick, you shouldn't see them in anywhere. The lymph nodes, they shouldn't be there. We do check a little bit of everything. Kids have such weird things. Ears can be lower, missing pieces, skin tabs. They all mean different things in kids. We can listen to their heart. Do they have murmurs, etc.? The abdomen on kids are big and round. Are they distended? Are they loopy? You know, do we have bowel sounds? All of these things we look at. Genitalia. Do they have proper genitalia? The one thing that I didn't know about was fused labia on young little girls. I'm like, oh, what is that? I hadn't seen it. I mean, this is in the beginning when I first started in the ER. I worked cardiac and newborn ICU. I hadn't seen it. All they do is put some hormone cream on it and it opens up. I didn't know that. But again, you know, what if I have to go and do a urinary catheterization on a little girl infant that has fused labia? Can you imagine trying to get a catheter into there? I've done it, but it's hard. Do you realize sometimes babies are born without an anus, called an imperforated anus? I have never seen one. Been a nurse a long time. I never saw one of those. Again, there's no exit. So that's an immediate, they need surgery, a colostomy to do something with the excrement that's going through the GI tract. We look at the back, making sure that the back is closed. There's nothing hanging out of there. We look to make sure everything moves everywhere. We check reflexes. In an infant, taking and clapping your hands above them, that noise, they should splay their hands and their feet should come up. That's a moro or a startle reflex. So we check all those things. In infants, we're checking their head circumference every shift. We're making sure they don't have hydrocephalus. When a baby's born, their heads are big and their chests are smaller. But as they get older, by about 1 year old, the chest and the head should be equal. Or the head should be less than the chest. The chest gets bigger than the head. Why is the head bigger at birth? It's got to push the chest behind it. It's got to make room for it. And that's why the head is bigger at birth. We always look at abdominal circumference because that shows us when they're eating, is it going down? If we're seeing an increase in abdominal circumference, that means the food's not being absorbed. So we need to be careful with that. Checking the height and weight at admission or in an ER or a doctor's office. Again, height and weight, as I said, will show us so many things. Show us nutrition, show us about our hormones working, our thyroid hormone, our growth hormones. Is everything right? So a height is important. Little kids are afraid of that wooden board coming down and bopping them on the head. So I would have to play games every time I get a kid that size that walked into my triage room. So what would I do? I get on the scale, turn around, take that wood thing, hold it, and touch, go bop. Oh, it just touched my head. There it is. All right, let me see, what's my number? Oh, I'm a number 7. What's your number gonna be? Now this kid thinks it's fun. I've made a game. They're gonna figure what their number is. So we put them down, hold, go bop, bop. Did it touch your head yet? Oh, there it is. Okay, what's your number? I took 2 minutes to do it, and I got an accurate height, which is what we need. And that kid's not upset, not angry, and they're happy because we played a game. And that's what children's all about. Blood pressure cuffs, again, you got to pick the right cuff. There's all sizes from 000s all the way up to extra large. I actually, on most of my toddler, preschooler, young school age, I will do number D. I will put it on their lower leg. And the reason is, it doesn't hurt. I hate my blood pressure taken. That thing always pinches my arm and it hurts in the upper arm, right? I put it on the lower leg and I get an accurate blood pressure. And again, the kid's not angry with me and not upset. So pain, you see my dissertation is all about, injections and pain and decreasing that pain and anxiety and stress of injections, something that I've always focused in on. And I've been working in pediatrics since the 80s. I remember being in the newborn ICU at a big county hospital down here. And I remember seeing a surgeon come into the room on a little baby with a condition called Pierre Robin. The tongue would fall to the back of their throat, tiny little jaw. It's a condition, Pierre Robin. And what that surgeon did is, without sedation or anything, took a suture and put it through the lip into the tongue and tied it to the lip. And I'm like, hello, can we give this kid something for pain? Can you imagine sticking a needle through the lip, through the tongue? That's in the 80s. That's the difference of today. Today, that wouldn't happen. Okay? Not at all. Back then, it was different. They didn't even have sedation on children in ventilators. Completely different than today. Today, we know better. Back in the early 2000s, the Joint Commission, accrediting agency that comes, make sure our hospitals are functioning up to standards, their standards, they came and said that we were not evaluating pain the way that we should. So we felt that children, I mean, this was adults too, they were talking about, but they were not being treated. And what are we doing to make sure that those kids got better treatment? So we found out that kids are always going to be suffering from inadequate pain control because of what? Well, back then they didn't have a proper assessment form. They developed something at my hospital called PI, which means you figured out a plan for the pain. I is the intervention that you did, and then E from PI is we evaluated, did that medicine, that intervention work? And that's the program that was developed to make sure kids had less pain. But we still have nurses that don't give it on time, the medicine, that all say, well, they're getting morphine. That's too much morphine. They can't have that much. Now, morphine is probably one of the most longest, oldest medicines that we use. We probably understand it better than most medicine. So we know dosaging, what is good for kids. So again, giving less than they should, it doesn't really help. Another thing is that we found again, and we changed that, is going back and check, did it work? Are you feeling better? Pain isn't just medicine. What else do we do for pain control? Distraction. Children, distract them. Number 2, hot packs, cold packs, positioning, elevating the head of the bed if they just have abdominal surgery. Give them a pillow to splint. All of those things are part of pain control. Now, kids, how are you going to figure out from 0 to 10? 0's no pain, 10's the worst pain in the world. Tell me, how are we going to figure out this child's pain level if they can't talk? Well, there's a scale, from ages 0 to 3, up to age 3. At 3, it changes to something else. From 0 to 3 and non-verbal children, we can do these. We look and do pain control and figure out a level from 0 to 10. So we look at their faces. Are they grimacing? Okay. Or are they smiling and giggling at me? Their leg movement. I know, it could be a child that's not moving because they hurt so bad, or they could be wiggling because their tummies and everything and they hurt so much. It could be either or. And that has to do with activity. And are they crying? And if they're crying, can I console them? There are kids that are crying that you console them. It's easy. And there's other kids that they hurt so bad that you just can't. And they're not consolable. Again, it's also used for non-verbal children. It could be an 18-year-old cerebral palsy child who's nonverbal. Could be used a FLAC scale, 0 to 3, and then nonverbal. Now, from ages 3, you can use this for adults if you wanted, forever. I mean, yeah, we have the numeric scale that the book says can start at age 8, but FLAC scale starts at age 3, and we could use it for all ages there up. And what it does is you look at a picture and the child points to which face looks like the way they feel. Do you know what I like about kids? They don't lie. If they have a 6 in pain, they'll point to a 6. If you ask an adult what pain they have, they're going to tell you they have a 12. They have a 20. They're never going to be as accurate as children are. Most people, okay? So again, they really do well. Ages 3 up, they will point to pictures. And of course, 4 and up, you have to have an intervention if they're having any sort of pain. So FLAC, 0 to 3, nonverbal. FACES scale, which is pointing to the picture. It is ages 3 and up forever if you want. And if we want, we can use numeric from ages 8 older. And again, don't forget that FLAC scale is not just for the young kids. It's for those nonverbal children too that cannot talk. We know there's all sorts of pains for all sorts of reasoning. We know that long-term pain has a big, big effect on everything. Physical, emotional, social, everything. If you're hurting, you can't concentrate on nothing else. Know that there, as I said, there are some special checklists for those nonverbal or impaired, cognitively impaired children, etc. Again, whatever the appropriate one for your child, for your hospital or agency, use that one. And know that, again, in pain, remember there are some cultures that do not like to admit they're in pain. I think, the dad telling the little guy who just broke his arm, oh, you don't hurt, it's fine, take a Tylenol, you'll be good. And they've got a double fractured tibia. I'm like, oh, please, that's enough of that. Again, sometimes I can see that, and culture does make a difference. So in pain management, as I said, it's not just giving that narcotic, okay? It's using distraction. Relaxing could be like a buzzy type of a blanket we put on some children. There's other things that we have for those cognitively impaired ones that we put on that actually keeps them calm. Don't forget about young kids, putting them and swaddling them up in a blanket, making them feel comfortable and tight and secure. And then the pacifier. Pacifier will always decrease pain. Sugar water, a little pacifier. And then little itsy bitsy premature babies. People in babies in the newborn ICU. It is the most amazing thing to watch. A little premature baby who's in a warmer or isolate, and they're fussy and they can't get comfortable, and you see their heart rate up and their blood pressure up. Mommy comes in and says, can I hold my baby? And you take it out and give it to mommy and put it right on their skin. Kangaroo care. And you look at the monitor, this kid goes to sleep, heart rate comes down, blood pressure comes down, and they both go to sleep together. It's just the most amazing thing that kangaroo care can help these infants. It's that skin to skin thing. And I love doing that for parents. Remember, it's just not all the other stuff. We can, in between doses of narcotics, give acetaminophen or give an ibuprofen. Absolutely. And older kids, we can give them that PCA pump. There's lockouts, there's safety on them. We do it with adults, we can do it with older kids when they're having some big surgeries done. Remember, kids and atraumatic pain, using these type of numbing stuffs. We have numbing stuff that we use when you have lacerations before we put sutures in, before they put needles with lidocaine. We have numbing topically we put on. This picture is Emla. This kid's going to have some lab work done in her anticube space. And she's smiling because she knows that white blob of stuff is numbing the skin. So when they put the needle in, she won't feel it. And she knows that. And again, we teach the older kids stuff like that. We don't want kids that suffer in pain. That's all they're going to think about. I mean, look where pain comes from. Teething, immunization, circumcision, surgery, etc. Kids. So, which of the following is an important factor for consideration in understanding the pain experience in children? What do you think?
B. Maybe.
Exactly. And the reason is they don't want the shot, they don't want the liquid, or they don't want to disappoint their daddy because he said no, right? Let's go ahead and do our first cahoots. Any questions with everybody? I haven't bored you to death yet?
No, not yet.
Not yet. I like that. All right. I'll continue to try. Don't worry. Who wants to win a Kahoot today? Remember, I'm going to be sending this to you. You're going to have them and you'll be able to practice them. It's a great thing to do before quizzes and exams. Hint, hint. Make sure that you go over the concepts. If you don't understand them, go to the PowerPoint, go to the book, look them up. You still don't understand it, come to us. We can help you. Can you see that?
Yes.
Okay, you can either do Kahoot.it, put the number in, or take your phone cameras and stick it on that, and you go right to the game. Now, I go over these Kahoots every single term. I'm always infusing different concepts, different questions, according to what I'm seeing on the HESI results. I get little GI, let's say, irritable bowel syndrome, and that was going to be the concept. So I got to figure out what question could be asked, and I figure questions. That's how Kahoots are made. I make them. And as I said, I've been doing this for, I think I started them back in 2019. So 7 years so far.
So this
Okay.
is something very new for me. I don't.
Okay, what you're going to do is you take your phone and you use that. And that's going to come up with colors, red, yellow, green, and blue. On the screen, you're going to get a question soon. And that whatever answer, red, yellow, green, or blue, you touch your phone on that one.
Okay.
Okay.
Thank you.
You're very welcome. It's how I had to learn. I asked the question too. One. Gonna go by quick. The leading cause of death from unintentional injuries in children is unintentional injuries, children. As I said, injuries in children, unintentional. They didn't mean it to happen. Motor vehicles. Infants, they're not secured correctly, whatever. That's an accident. toddlers, preschoolers being run over by motor vehicles. And that's what happens because now they're more mobile. And think about adolescents. They now have a driver's license. So again, unintentional injuries. Statement is most descriptive of pediatric family-centered care. What's a family? Those are the other people you've got to take care of. You don't just get a kid, you get the whole group. You know, I've made lifelong friends from parents. Remember, a family is the only constant in their life, which means it's their comfort. It's the only thing they know, the only thing they understand. They know what you do and why you do it. That's their constant. Everything else scares them, okay? Family is the only constant. The major cause of death for children over 1 year old is I've asked the same question in a different way. So this is unintentional injuries, okay? Again, they're not because somebody wants to do it to them, it's things that happen. We know that kids by age 1 now are mobile. They have no filters. They can take and jump on couches, try to jump to the next couch, hit the floor, hit their heads. This is what they do. This is part of those unintentional injuries and things that can happen. Seeing them climb up fronts of dressers of drawers to get to TVs, and TVs come over on them, and all sorts of things. Yes. The nurse caring for the child in pain understands that distractions remember, distraction has to be at a place where the kid understands it. So it must be developmentally appropriate. Again, you don't give an infant a sticker to distract them. You might take a rattle and rattle from them so that they focus somewhere else. Give them a pacifier. It has to be developmentally appropriate. It's not going to work. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? This is your preschoolers. They're playing all together. They're sharing all the toys. There's no goal. And that's called associative, okay? Okay, you'll remember them after you keep going. That's why I keep doing it again and again. Which statement best describes the process of critical thinking? Do you remember the first day of nursing school, the dean came in and said, we're going to teach you how to think critically by the end of this program and how to put things together? Well, you critically think every day. You had to go to the announcement, get my Zoom log to get in, and you had to figure out how to get on the Zoom log. So it is purposeful and goal directed. You needed to get to me to go to class, so you did, and you figured out how to do it. That's critical thinking. Did you have dinner? You had to figure out what you wanted. That's critical thinking. Again, that's how easy it is. Which is probably the single most important influence on growth at all stages of development. Nutrition, nutrition, nutrition. If you don't put gasoline in the tank, it's not going to get up and go. If you don't feed a child, they're not going to be cognitively aware, and they're not going to have the height and the weight, and they're going to be behind. So again, nutrition, nutrition, nutrition. Which function of play is a major component of play at all ages? What does play do for them? What did I say about play? So play is all about the senses. It's the smell, the touch, the sight, the sound. They see that. And then they put everything in their mouth and explore it and feel it because that's what kids do. And then, of course, they take it and move it around and play with it and motor it everywhere. Sensory motor activity is all about play. That's what you do. Today, it's what you do. It's still that. Do you apply nystatin to an infant with thrush? Now, I threw this question in because I want you to think about peds is different from adults. Pediatrics are not little adults. They're different. And they're all different to boot. Not any two pediatric child's the same, even the same diagnosis, born the same time, the same year. It doesn't matter. They'll both be different. Okay, so you don't swish and swallow like an adult. It doesn't work. And then it won't get on the tongue where all this white patch thrush is. You have to take a cotton swab and paint it on there. Again, think about the differences between children and adults. Okay, always think of that. That's why I threw this in here to bring it out. 3 children playing a board game would be an example of what? Those are your school age children. And this is cooperative play. Good job, guys. Remember, there's 2 or more children playing together, and there's a goal. Somebody wins. It's checkers, it's Monopoly, it's whatever. Or we made a race car set. That the castle, the sand castle's done. That is what we're talking about. Good job. The head to tail direction of growth is referred to as. So you're looking at these words, figuring out, gee, which one could it be? Think about what the word is saying. It's from head to foot. Cephalocaudal, cephalic is a head. That's how you remember cephalocaudal. They lift their head up first and they end up with walking on their feet or attempting to walk by 1-year-old. Cephalocaudal. Proximal distal is talking about stuff and toys. They first start looking here and then they go into their periphery. It starts here, proximal. Then it goes out and they explore the world. That's what that one means. Sequential means you have to go in a sequence. You start, lift your head, then you roll, then you creep, then you walk. Okay, it's sequence. And I don't know what a mass to specific is even talking about. It's a good word. What is the single most important factor to consider when communicating with children? So when you're talking with kids, first of all, you get below them so you're not threatening and on their developmental level. If you're talking to, a preschooler like you would speak to an adolescent, they ain't going to understand. You've really got to get on their level, make them understand, and make you non-threatening because they don't want to like you because you're the bad person. You always give a shot. What 2-year-old child pain assessment tool should the nurse use? So remember, I've gone over 3 different types of pain tools. What is good for a 2-year-old? So less than 3 and nonverbal is flack. You need to know these scales. You need to know what is used for what age child, okay? 0 to 3, it's flack and nonverbal children. At age 3, it becomes faces. They can point to the faces. And you can use that for adults too if you want, but you can also use numeric, and that doesn't start till age 8. At 6 months, an infant's birth weight should do what? So at 6 months old, it should double. At 1 year, it should triple. I mean, these are key things. You're going to see these things again. These are those basic developmental things that will be looked at closely. Because remember, nutrition, nutrition, nutrition. They're not gaining weight the way they should. They're not getting nutrition. Cognitively, they're not getting what they need. And they're not going to have the height and weight because they don't have the gas to put in the tank to make them grow. Okay. The first expected fine motor developmental milestones for an infant begins with what? So the first, remember, F for fingers, fine. F means fingers. So that's fine motor skills. It has to do with the fingers, the hands, what it does. Gross motor skills is get up and go, go, go movement. Okay. So fine motor skills has to do, the first thing is mommy puts her hand next to the baby, and by reflex, the baby grabs it. And the mother goes, oh my goodness, my baby's just gave me a hug on my finger. Don't ever tell them that the baby, that was a reflex. Let them think that that baby just grabbed a hold of that hand and given mommy a hug. It is a reflex. After that, they realize, oh, there's this rattle. Let me grab it myself. It becomes voluntary. All right. The next thing that happens is now you put them in a high chair and start to feed them. And they take their fingers to feed, right? First thing they do is what we call a pincer grasp. It can be like this in the end, but it starts out with like a smush in the face. It's not as fine. So that's crude pincer grasp, okay? And then it gets to the point where it becomes the fine pincer grasp, okay? At 8 months old, an infant should be expected to perform which fine motor skills?
Professor, you're muted.
Thank you so much. Appreciate it. Remember, an 8-month-old should be able to grab whatever. Okay, they've done the voluntary, the reflex. Now they can grab it and they want it, right? They also are going to take and try to feed themselves. 8 months. Remember, they're sitting unsupported by themselves. They're sitting in a high chair now and they're trying to put stuff in their mouth. It's not that fine pincer, it's that get it into their mouth, sort of, the first thing they start to do. Very good. The natural physical developmental sequence that most children follow is what? Physical, gross motor skills. Physically, what do they do? So we know the first thing a kid should do, an infant, is they lift their head. That's by about 3 months. Then they roll from their abdomen to their back at 5 months, back to abdomen at 6 months, Then they're up on their knees and they're crawling. Then they stand up and they start holding on to things, creeping around coffee tables and around the sofa. And then they're by 1 year old, they should be walking or attempting to walk. So very good. Which behavior indicates that an infant has developed object permanence? Now, I didn't go over this, but think about an infant. They have their own little special toys they like, right? And they go looking for them. What this tells you object permanence is even though they can't see their favorite toy, they're going to look for it. Think about that kid who knows what toys go in the toy box at night. And what's going to happen that next morning when they wake up and they want their favorite toy? They know, even though they can't see it, they know to go search for it, they're going to find it and that they can get it. That is object permanence. In general, an infant should triple their birth weight at what months of age? So double at 6 months, we should triple at 1 year. And do you know we quadruple at age 2.5? Can you imagine we have to wait for another 1.5 years for them to quadruple? They slow way down at 1 year old. Perform a head to toe assessment on a toddler. Most important to consider before beginning that examination. So when before we start any examination, we know we're going to first get down to their level. That's always it. We never try to tower over any kid. They don't like it. They're threatened by it. But the most important thing is to base their examination on their developmental level. I mean, you're not going to be able to do things on an infant, if the mother's not holding them, they're going to be screaming and crying. I mean, you've got to, again, make sure it's on the level of the child so that you can get what you need done a lot easier. According to Piaget, toddlers are in the blank developmental stage up to the age of 2. How do they play? How do they explore? It's all about that sense, that sight, that smell, that touch, that hearing about it, the taste of it, sensory motor in the mouth and it's moving around. That is what they're all about. Infants up to toddlers, age 2, sensory motor. Intervention helps a hospitalized toddler feel a sense of control. I think probably the hardest group of kids to have in a hospital admitted is this toddler, ages 1 to 3. They're very into mommy. They're very into all of their little routines at home. And when we break them and their routines, they are not happy. So one of the things that we can do is I want the parents to stay with them if they can. But the other thing is maintaining the same routines. And if we can feed them the same types of foods they like, that would be good too. One of the things that we think about with routines is bath time. If you give the bath every night and you give it in the morning, that kid's going to be confused. They don't know that they're not going to bed now. They just woke up. What's happening? So again, especially if they're cognitively impaired type of toddler also. Again, you've got to keep them on that same sort of schedule. It keeps them happier. That's what they want. They want to know what's coming next. Do all children reach developmental milestones at the same age? I'm glad you answered it that quick. Absolutely not. I mean, kids are all different. And as I said, this is what makes kids so special because they're not the same. I mean, in an adult world, an adult going in for a gallbladder, they're all going to have the same orders and have the same outcomes and do the same things. Children will all be different. They're never the same. And that's what I loved about it. It's the challenge of thinking about the kids and where they are instead of just same routine, everybody the same. Immunizations for a 4-month-old infant. Which action should the nurse take to provide atraumatic care for an infant? So, immunizations, atraumatic care, infant. It's all about the pacifier and it's all about just a little bit of sugar water on it. Actually, they have these little commercial things called sweeties. These are like a little purple little ampule plastic thing. And it's like a little bit of sugar water and you drip it on the end and it doesn't give them nutrition. That's not what it's for. There's something with the sugar water and the sucking that gives these children comfort. So pacifiers are, I'm telling you, for circumcisions, for starting IVs, immunizations, anything, it really, really works very well. Which of the following immunizations is administered to a newborn? Now, next week, we're going to talk about infants. And if you look at the chapters, there's a 2-page spread on immunizations and when do we give them and what do we give them? And you're going to be confused with them all. I'm going to try to show you what comes first, second, and third. Hepatitis B is the first one that we do give, and usually we give it in the hospital before they go home. When we do DPAP polio, those are 2, 4, 6 months that we give them. And MMR is 1 year to 15 months, around right there, okay? When you're giving immunizations, especially that first 2, 4, 6 months, you're giving 2 to 4 immunizations, injections in those vastus lateralis, right? So one of the things we teach you for atraumatic care, number one, we can put numbing creams, we can, put ice on it first, we can do a lot of things, but afterwards, pedal the legs to get that immunization liquid scattered out there. And if we get any sort of heat afterwards, and sometimes fevers are expected and normal after immunizations, we can put a little bit of coolness on those areas and a little bit of acetaminophen do work on those first sets of immunizations. A normal heart rate for a neonate is so a neonate, the first 28 days of life, normal heart rate is 140 to 160. You need to understand the heart rates and where they are because you're going to see this in relationship, like when you're giving digoxin. When should you hold the dose? What is a high heart rate? What's a low heart rate? When do they have pain? When are they dehydrated? When do they have fever? You need to know the heart rate or just about that you can figure out some of these scenarios just by heart rate. What is the preferred site to give an injection to an infant? And I don't like that picture because somebody should be holding that infant's hands. Usually mommy holding the hands and talking to him with a pacifier, helping to hold the pacifier in. And yes, it is in the vastus lateralis. They do that until they're up and they're walking before they start changing places. The death of an infant under 1 year old with no known cause. We're going to be going into the reasons for the increased risk for SIDS death next week in the infant section. But this is the first 1 year is when we worry about Sid's death, the first 1 year of life, and it's sudden infant death. The Vietnamese mother of a child avoids eye contact with a nurse. Considering cultural differences, why doesn't she look at that nurse? Why aren't you looking at me? Again, this is another cultural thing, and it's respect. And if you don't understand why they're doing things, I have never had anybody be upset for me to ask. Why can't I touch you? Why can't I tie your shoelaces? Why aren't you looking at me? There's a whole lot of different things that I've seen. Again, ask the question, why aren't you looking at me? You'll be surprised with some answers. A child from Mexico is hospitalized for a serious illness, and the father says the child's being punished by God. He's saying that. So again, Mexicans and this father basically believes that this is when he does something wrong or something happens to him, they've done something wrong, so they're being punished. And they have their own ideas. Well, I didn't go to work yesterday, so my kid's being punished. Or I didn't do this, so my kid's being punished. Or the kids hit this kid yesterday or hit his sister and they're being punished. They believe in things like this, okay? And sometimes it's us talking to them and helping them say, nobody did anything to hurt this child. That appendix burst because it didn't want to be there anymore. Again, sometimes us as nurses can help parents calm down. Each term refers to a times in an individual life where he or she is more susceptible to positive and negative influences. Again, this is called the sensitive period. Good job, guys. Is characteristic of the pre-operational stage of cognitive development. This is the first 2 years of life. And I'm going to help you understand what these words mean once this question's done. Because it sounds like a bunch of garbage, gibberish. I don't understand what's logical, what's inductive, what's concrete, right? All right. Why do I say pre-operational? Young kids, okay? Thinking is concrete. What does that mean? Well, concrete, you can see it, touch it, taste it, feel it. I've seen it before. I can replicate it again. Young kids cannot do something if they've not seen it before. It's concrete. I know it. I've seen it. I can do it for you. Do you understand that? Not logical. They don't understand logic yet. They know that I've seen it before. This is the way it's done, and I can do it. That is concrete for them. I don't have to figure it out. I've seen it. According to Kohlberg, children develop moral reasoning. What is a preschooler's stage of moral reasoning? Remember Kohlberg, I said, infants and toddlers do not understand right and wrong yet. They don't have a morality yet. They just do what they want to do and they figure it out. And mom and dad say, no, don't do that. Be careful. And then you become a preschooler, and now they understand right and wrong, but they understand the consequence. They understand if I do something good, mommy's going to be happy with me. Maybe I get a reward. But if I'm bad, I'm going to be punished. Maybe go to my bed soon or get that something taken away from me. Right and wrong, and there's a consequence for them. That's what they understand as a preschooler. Number 3, Daranique. Good job, Daranique. Vanessa, number 2, good job. And number 1, drum roll, bing, 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 bing. Judy, Judge Judy, I love it. And Nikisa and Catherine. So that's all I have for today. Now, anybody who needs help with math, dosage calculation, let me know. Send me a message. Remember to think about your diagnosis that you want to do for your pediatric assessment project. I mean, you don't need to give it now. It's for week 8. But I'm telling you, if you wait to week 8 to try to get this whole project done, you're going to be drowning, because community also has a project around there too. And MedSurg is going to become a bear around that time. So figure out what you want to do. Send Professor Harbor a message saying, hey, I want to do this one. She'll say, I approve. Start with your paper. That's a great place to start. It's only 250 words. It's not a big deal. But remember, we put it through plagiar checkers. So please use your own words. Don't give me any AI hangout. No, it won't work. It's going to show up as a plagiarism. Okay? Any questions from anybody about anything?
If we want to play those Kahoots like on our own, can we?
Absolutely. I'm going to be sending you the link. You can
Okay.
click on it and play alone if you want, or you can click on it and play with one of your classmates, whatever you want. They're there for you. Yes, they're yours.
Competition, I like that.
Anybody else, any questions, comments, concerns?
Professor Bogart, I did have a question. I just wanted to get familiar with the SurePath Vantage.
Okay.
Is that a requirement for us to be reading, or is that just a resource? I'm sorry if you
It's
went
a
over that. I might have
resource.
missed.
It is a resource. The SharePath Advantage we're using to do the adaptive quizzes. Furthermore, in that, you also have the ability to make up your own quizzes, make up your own case studies. There's so much tools in that thing if you want to play with it and use it. You know, there's a lot. Yes, Ty Tiona. Miss Williams. She left me. Anybody else with anything they need to know? Well, that's all I got for tonight. You all may leave and take a little time, go kiss your kids goodbye, have a dinner, and get ready for community.
Awesome.
It was nice meeting you all. Again, I'm always here if you need me. You can always reach out to me or Professor Harbor. She's right there also. Whatever you need, we're here to help you to succeed and get through this course. I want everybody to pass this course. All right?
Thank
You've got to help me.
Thank
You're
you.
welcome.
Thank you.
You're welcome.
Thank you.
Thank you.
You're welcome.